Hello everyone, my name is Nicolas Aronna and this is the online classes of Dental Surgery channel. Today I want to share with you a case that was recently treated with two central incisor crowns, and one of the other areas that she had to treat was a molar that was affected because of a big abscess that she was having. So I want to share with you the case, and the patient actually came to the office like this, like the one you see. Here we took a panoramic x-ray, and she's got other issues in the mouth, but one of the issues that affects the most because it actually hurts was this abscess, this endoperioral lesion. And when I consider an endoperioral lesion, it's because it involves two problems. One, it's because maybe there is an endo problem that is developing also a periodontal problem. So initially it was developed inside the tooth, but then the drainage might drain into the periodontal ligament and end up with that periodontal ligament affected. So in this case, many things could have been happening, or many things could happen to this tooth. But the tooth actually, when we saw it, presented a little bit of mobility. The sounding was quite deep. It was like 9 to 10 millimeters in the lingual aspect, and we were expecting some obviously lingual bone loss. But at the end, what we did was to take a CBCT, and I want to share it with you. I want to share with you the case, and I want to share with you especially the rationale of using CBCT today, not only for implant diagnosis or implant planning, but it's very important to use the CBCT for many reasons. In this case, we want to see the extension of that cyst. But not only the extension of that cyst, we want to see the cause of the problem. So biologically, we will move a little bit more confident throughout all the process of diagnosing the patient when we know the cause of the problem. We know why things are happening. And this is why I wanted to take a CBCT. I wanted to take a CT scan to the patient to see whether the problem was coming because there was maybe an untreated root canal, or because there was any fracture or a crack. Usually when we have a crack, we have a very deep pocket, and when we have a non-treated root canal, the only way to see it is by taking a CBCT. So please remember that the CBCT is not only for implant planning. The CBCT will always give you important information, more information than you would ever imagine. I've seen so many CBCTs in my life, and at least 50% of them, I've seen other things that not only the things that I was looking for, but other things that were developing additional problems. And this is not only good for you, but also for communicating to the patient, communicating with the patient all the problems that the patient have. And obviously that is going to have an impact in your professional development, because the patients obviously are going to see you as a reference, because you're not only studying the problem, but you're also diagnosing other problems that the CBT is giving you information of. So if you're going back to the case, and this is the case that we actually are treating today, or we treated today. It's a number 37, it's a lower left second molar that developed this endoperioral lesion. Initially, when I take this panoramic x-ray, what I do is before taking the CBCT, I take a periapical x-ray, because the periapical x-ray will also give you a more detailed image. But then, obviously, if you go to the clinical situation, what we see a pocket from the lingual. We not only see a pocket, but we see a redness here. We have an inflammatory tissue. There is a bleeding on probing as well. We see a crown that is a little bit filtrated from those margins. And obviously, this is the lingual aspect of the patient. And this is why here the CBCT is very important, because when a cyst is draining through the buccal plate and it's draining all the suppuration to the intraoral area, the patient is going to swallow that abscess or the drainage of that abscess. But if the periapical lesion or the abscess is draining into the part of the inside of the mouth or the bottom of the mouth, very complicated and very dangerous problems may develop. This is why it's very important. The CBCT will always give us information regards the extension of the cyst and also regards the bone loss that actually provoked that extension of that cyst. So if we took a look at the CBCT and we see the horizontal aspect, the transversal section, we can see the extension of the cyst, buccolingual and mesiodistal from the most apical or coronal aspect. But the most important is to see this cross section in this case, because this is the buccal and this is the lingual, this is the inner oblique line, this is the concavity of the mandible, and this is the proximity to the inferior alveolar nerve. Also, whenever we have a cyst, it's very important to see how far or how close we are to the inferior alveolar nerve, because in order to remove completely the cyst, we need to curette it. And remove it completely means that we need to really curette that bone. And at the end of our curette and at the end of the whole and complete cyst removal, we need to sound the bone. And we need to sound the bone and feel it that actually it's not soft. We are touching actually the bone throughout all the hole that actually this cyst was covering. So in these kind of situations, to see the proximity to the inferior alveolar nerve will allow us to know and notice whether we are close or not to the nerve. So if we are far away from the nerve, we will be able to curette the area in a very confident and very safe way, because we know that we're not scratching that inferior alveolar nerve. There are sometimes those cysts basically represent a bone loss that do not only remove all the bone that it's covering the most alveolar aspect, but it actually reaches the cortical of the nerve. And if the cyst gets rid basically or reduces the cortical of the inferior alveolar nerve to nothing, you will have a inferior alveolar nerve that is exposed to the cyst. And obviously if you try to remove and curette the cyst, you may curette also the nerve and make the patient to develop a paresthesia. And this is why, one of the reasons why CBCT is important, to see the relationship with the inferior alveolar nerve when you're removing a cyst that has a little bit of relationship. And also because one of the things that we are actually going to see is the integrity of the lingual plate, which I consider it also very important, and not many people are mentioning it. The lingual plate, it's very, very, very important. Whenever we are extracting a tooth, we must be careful not to break that lingual plate, because sometimes when we break that lingual plate, we end up with very sharp edges, and those sharp edges, if they are really, really deep, they may affect the lingual nerve. Why? Because the lingual nerve goes really deep inside, really deep at the bottom area of the mandible, and if you create a bone fracture of that lingual plate, you can create those very thin edges of that fracture that might find and face that lingual nerve and develop a lot of problems in terms of paresthesia to those lingual nerves, and the patient may refer some paresthesia on the tongue. So I recommend to use also CBCT to see actually the presence of the lingual plate, to keep the integrity of the lingual plate throughout all the removal of any wisdom tooth or molar, lower molar, and also to see whether the cyst is draining into the bottom of the mouth or not. Because when I see those clinical pictures, it might represent that there is some drainage out of the cyst area that is draining somewhere. So if I take another cross section and I see this cross section, this is where I wanted to reach. I wanted to get here. See how the lingual plate is really thin, and see how the lingual plate basically is completely broken? Well, if this cyst is really, really deep down, probably the patient might experience drainage of that cyst at the bottom of the mouth, and that might be very dangerous. In this case, we had luck because it wasn't that deep inside in such a lower situation. It was a little bit high, so the patient at the clinical pictures was already developing a little bit of redness and also some fistula on the lingual aspect. But this basically represents the importance of basically understanding the use of the CBCT, not only for implant planning, but also for diagnosing, also for measuring, and also for being confident and safe whenever you are going to perform a surgery. So CBCT, please, mandatory for a lot of things, not only for implant planning. Well, in this case, just to finish the presentation of this online class, I will leave you with a video of how we treated this case in terms of what the materials that we actually used in this case. We did the socket preservation first because we couldn't place the implant the same day of the extraction. First, because when you have a converged roots, there is no bone, remnant bone, that you actually can anchor your implant first. Second, when you have a lot of cyst and a lot of extension of your cyst, actually removed a lot of bone, you're not going to find too much bone, and that will compromise the appropriate implant placement. And third, we are going to do a socket preservation to not only preserve the volume, but also a little bit try to gain a little bit volume, because the patient was already suffering from some periodontal disease on the first molar. So we wanted to make sure that whether the patient actually wants to have the implant or not, sometimes it's good to place bone graft and preserve the socket in order to allow the patient eventually, as long as the antagonist tooth does not over erupt and basically covers the prosthetic space, but also in order to give the patient opportunity down the road to place an implant, and also to protect periodontally the distal aspect of the first molar. So remember that socket preservation is not only to maintain the volume or gain volume. Usually it's to maintain volume. Usually you do not gain volume, but also it protects the adjacent teeth from developing a periodontal problem because of the bone loss that will provoke the extraction and the removal of the cyst without doing anything. So in this case, we did the socket preservation with growth factor therapy. We mixed the two fractions. Fraction 1 was used to do fiber membranes, and fraction 2 was used, the one that is closer to the buffy coat, the one that is richer, more rich in growth factors. We mixed it with beta-2 calcium phosphate, and we are expecting in 6 months to have a lot of bone there to be able to place our implant. So I hope that in this case you learned a little bit and I had the opportunity to share with you a little bit about my cases. I'm going to keep posting cases with a daily basis, and I hope that you enjoyed and learned new things about the use of the CBCT as a very important tool for not only implant planning but also for diagnosing and communicating with the patient. So now that we are in the era of digital, please use CBCT for many things, and I'm looking forward to see you here in Dental Surgery channel, the online classes in Instagram and in Facebook. Welcome.